Good afternoon, everyone, and thank you for taking the time to join us for this webinar. My name is Shanti St. Anthony, the Knowledge Coordinator for PANCAP based at the PANCAP Coordinating Unit in Georgetown. Let me extend a warm welcome to you on behalf of PANCAP and PANCAP's Director, Mr. Derek Springer. Thank you for joining us. Thank you also on behalf of the USAID-funded Shops Plus project. At this point, I'd like to share with you a few housekeeping notes. Firstly, your mics are muted. If you have any questions, we ask that you type these in as the presentation progresses. We'll address them during the question and answer segment after the presentation. Secondly, please be informed that the webinar is recorded and will be shared on PANCAP's website for the benefit of the wider partnership. Finally, you'll receive a post-webinar evaluation. We encourage you to complete this and share your thoughts and impressions with us. I'll now introduce to you our moderator for today's webinar. Sarah Insalani is a Senior Associate in the International Development Division of Act Associates Incorporated, and is the Guyana Country Lead for the USAID-funded Shops Plus project. I now hand you over to Sarah.
Thank you, Shanti, and good afternoon, everyone. Thank you for joining us. My name is Sarah Insalani, and as Shanti said, I'm the Guyana Country Lead for the USAID-funded Sustaining Health Outcomes through the Private Sector, or Shops Plus project. On behalf of Shops Plus and PANCAP, it's a pleasure to welcome you to today's webinar, Beyond the Hype, the Nuts and Bolts of Government Contracting of Private Facilities and CSOs. Our objective this afternoon is to provide practical guidance on a range of issues related to social contracting, and our speakers are well placed to do so. We're excited to have with us Dr. Maurice Edwards. He is the Executive Director of the Health Sector Development Unit of the Guyana Ministry of Public Health, and he will speak on ensuring CSO contracting is in the national budget. Dr. Sophie Fay is an economist working with the Shops Plus project, and she will speak on costing social services for the HIV response, a guide for CSOs and commercial and private commercial service providers. Dr. Edwards and Dr. Fay will each speak for about 10 minutes, and after that, we will open the discussion for your comments and questions for the speakers. Feel free to go ahead and post your questions as they come up during the presentation. So let's begin with our discussion with Dr. Edwards. Dr. Edwards, good afternoon. You have been leading the Government of Guyana's social contracting efforts. Can you begin by telling us why it is important for the Government of Guyana to contract CSOs?
Good afternoon. Thank you, Sarah, and good afternoon to everyone. There are basically about three reasons why it is important for the Government of Guyana to contract CSOs. One being that we know that CSOs are better able to reach key populations than government entities or agencies. The second reason being that donor funds to the region, Guyana being one of the countries there, have reduced significantly. Both the Global Fund and PEPFAR have reduced their contributions to Guyana. And in order for us to sustain the response, the government needs to have an engagement with civil society. And this can only be done through social contracting. And finally, in order for us to sustain the gains that we've actually made so far, then the government needs as many partners on board, and this can only be done with civil society through contractual arrangement. So social contracting is extremely important for us here in Guyana to be able to sustain the gains that we have made in our HIV response.
Thank you. And what do you see as the main concerns or challenges related to subcontracting CSOs?
There are a couple of challenges. One, using Guyana as the example, the ability of the civil society organizations to actually deliver on the services that they will be contracted to deliver in the time frame that they are given. Secondly, the ability of the government to actually monitor civil society organizations that they would enter into this contractual arrangement with. The National AIDS Program has its hands full currently in trying to coordinate the national response, and then now to have to actually go out and monitor civil society organizations as they implement through a contractual arrangement. They're going to be stretched to achieve that. The third thing being that the ability of CSOs to actually deliver on a range of services. In the context of Guyana, currently, social contracting is for preventative services, prevention services. With the reduction in donor funds, treatment services need to be scaled up. And currently, civil society organizations don't necessarily have that capacity. And so if the government wishes to continue to go the route of social contracting to deliver care and treatment services, it's going to be a challenge for civil society organizations.
Thank you. So I know that this is a new area for the government of Guyana, but the government and the Ministry of Public Health has had experience with subvention. Can you talk a little bit about how subcontracting is different from subvention?
There's a fundamental difference between subvention or a subvention arrangement versus social contracting. With subvention, the different departments of the particular ministry, let's for example use the Ministry of Public Health. If it wishes to engage in a subvention arrangement with a particular entity, this has to be an entity that the ministry knew beforehand could provide certain services or help the ministry to provide certain services, or this particular entity had a previous arrangement with the government. So for example, we have what we call the Guyana Responsible Parenthood Association that used to be funded by Population Services International, and they have a history of collaborating with the government, and they are given a subvention to help with maternal and child health initiatives. In that arrangement, the government or the particular department will determine what exactly it wishes to have this entity help to execute, and they give a pot of money to that entity. Now, I don't know how much actual real costing is done for the delivery of those services, and then during the budget negotiations, that amount can actually be reduced. So at the end of the day, a pot of money is given to that particular entity to deliver on services, and there's no competition. On the other hand, with social contracting, the government earmarks a certain amount of money, hopefully that where it has done a costing that these services will cost X amount to deliver, and the government then advertise. So it's a transparent process. More persons or more entities have an opportunity to submit proposals, and those proposals are evaluated, and those that are considered the better proposals, they're the ones that are recommended for funding. So that's a major difference between social contracting and the subvention arrangement, at least in the context of Guyana.
Great, thank you. And then finally, can you tell us a bit more about where Guyana is in the process of establishing this new mechanism for social contracting? And specifically, how are you working to get subcontracts into the Ministry of Public Health budget?
Okay, Guyana is a little bit advanced in actually implementing social contracting. We started this process since early last year in the development, when we were developing our HIV sustainability plan. What happened, my unit, the Health Sector Development Unit, worked with the National AIDS Program, because our National AIDS Program, while it is its main responsibility is to coordinate the national response, it also does some amount of implementation. And so we asked them to look within their budget, their previous budgets, to see what resources they have allocated for implementing prevention services to key populations. We then entered into a negotiations with the Ministry of Finance to have this taken on board as a policy initiative. Luckily for us, the Director of Budget did explain to us that they've had previous arrangements where they've contracted entities in other ministries to deliver bodies of work. But the caveat for the national program, the Director of Budget said that for this to be something which becomes mainstream in the health budget, first it would have to be piloted. And so we then explained to her that this is not new monies that we are requesting. Basically, it's the monies that the national program had allocated for prevention services for key population, and we would make those funds available for organizations to actually submit proposals. So Guyana goes through this budget preparation cycle where from since June, July, that they have to determine what are the activities that they're going to be putting in their budget, because by the end of December, the Parliament votes on the allocations. So since June, we had the discussions, or prior to June, we had the discussions with the national program. Then we had the discussions with the Director of Budget in June, so that she was actually aware that this would be coming through in the National AIDS Program component of the Ministry of Public Health budget. And so that amount was approved. At the beginning of this year, once the budget allocations became available, we then developed the terms of reference, and then we advertised for the services that the National AIDS Program was going to advertise for socially contracting civil society organizations. So this was advertised in all of the newspapers in the country for a period of 2 weeks. And once the proposals were received, there was a subcommittee, well, not a committee, subcommittee. We had a group that actually reviewed all of those proposals and scored them accordingly. Those proposals that were deemed to be the ones that should receive funding, they were recommended to the Permanent Secretary for the ministry to enter into a contractual arrangement with those organizations to move this process forward. So we're just about to enter into that contractual arrangement with the civil society organizations. I must add, however, that the constraints here is that they have to deliver on their targets before the close of the fiscal year, and that ends in December. So all targets have to achieve between now and December.
Thank you. Thank you so much, Dr. Edwards, for sharing your thoughts and Guyana's experience. And we look forward to hearing more as this important initiative moves forward. I know this kind of information sharing is always appreciated in the region, so please go ahead and post your questions for Dr. Edwards as we move on. Our next speaker, Dr. Sophie Fay, will share a presentation based on her work to support a costing of services delivered by CSOs in Barbados. Sophie has some slides so you can follow along. Sophie, good afternoon, welcome. Sophie, can you hear me? Shanti, are you able to help connect Sophie? Thank you.
Okay. Hello, do you hear me?
Hi, Sophie. Yes, please go ahead.
Okay. Thank you so much for the introduction, Sarah. Thank you to everybody who joined us today for this webinar. And I think following Dr. Morris's remarks for Guyana, I want to talk about a work that we did in Barbados, helping community workers prepare for the same type of arrangement that Dr. Morris has described. So in terms of background, I think the situation isn't different from Guyana. In Barbados, we have a relatively low prevalence of HIV among general population, but key population suffers very much from the burden of HIV. And because of that, having CSOs provide these targeted HIV-related services is very important to them. They've been working with the Linkages project there mostly, and with PEPFAR transition, it was important to prepare the CSOs to find new ways of funding or enter into the type of arrangement described earlier, social contracting or subvention with the government. So that's how we ended up as supporting them technically. This was done under the Health Finance and Governance Project, former project led by APT Associates. We helped in terms of understanding the cost structure of these CSOs, how much it's costing them to deliver these services, and particularly looking with them through scenarios of change in service delivery and how it would impact costs. And specifically in Barbados, there were interests from the government to add ART services to what was actually being offered. So we also helped them through thinking what this would mean in terms of cost. In terms of study design, we did work with two CSOs, Equals and Community Health, Community Education, Empowerment and Development, SEEDS. But we also requested and obtained data from the Barbados Family Planning Association, as they were already working with Linkages in providing some of these HIV services. The costing period is over 12 months, May 2017 to May 2018. And there I just want to note that it doesn't have to be 12 months. It could be 6 months. It could even be shorter time period, but the lower you go, the less beneficial it is compared to the amount of work you have to put into this exercise. So ideally, 1 year or 6 months would be better, especially if you want to stick to your budgeting cycle. For the costing, we used what we call the top-down approach. It's one approach when it comes to costing, and I'm going to talk more about it in later slides. And I want to note that this costing was on the CSO perspective. So anything that a beneficiary would be spending to access these services isn't part of our costing. It's all that is spent by the CSO. So we just don't have enough time today, so we just decided to share example from one of the CSOs, and even there the results would be just selected results. There's much more about this costing study in terms of the methodology, the resources that was needed on the CSO side, that you can find in the report that was prepared for this work. And I will share the link at the end of the presentation, but it is on the HFG website. But for this example, we see that the CSO have 3 broad categories of services: HIV testing, support group services, and other related social services such as housing support or psychosocial support, as well as outreach support. And each of these services at the end of the exercise should come with a total cost for the service and also a unit cost depending on the number of beneficiaries / event that happen under this service. So a key consideration for this exercise of costing is that you have to work with what the CSO have. And when I say what they have is whatever they have in terms of cost data, expenditure data, and how they're tracking it. And the difficulty will really be there you want to see what they have and organize it in a way that is meaningful to your costing, and definitely would be meaningful as an output in terms of basing it, basing decision on it and interpreting. So in this case, we thought it would be important to just bring this cost and categorize them. And you can see here the biggest categories that we came up with was payroll costs. So everything that is paid to the HR of these CSOs. And we have two distinctions there. The direct payroll, we considered everybody who is directly providing the services. So outreach workers, workers in charge of testing, like nurses type workers. And then you have the indirect payroll costs, which is mostly administrative and support staff, supporting the functioning, but not necessarily providing the services directly. Overhead cost is another key component. And this is everything that would help run the CSOs as rental costs, if they're renting their building, utilities. So these are important costs to make sure that they are controlled. We also have a third category, which is everything that's more directly related to service provision. And inside this big category of service provision cost, we have the fixed and the variable one. So it was important for us in this case to distinguish between fixed and variable. And when I say fixed, I mean mostly those things that don't change with the volume of services provided, like the number of beneficiaries won't change much because of this cost. An example would be training for the staff to get specific skills when it comes to, counseling or just the testing. So that cost won't really depend on how many people you test. It's already there, no matter how many people you end up testing, compared to some costs that could be more variable, such as refreshment provided during the support group or consumable that you need as part of the testing process itself. So those things would increase as your number of people increase. So it's important to just make that difference in terms of how you're going to use this data later for budgeting purposes. And we try to do it in this case. So this data organized in a way that we wanted it to be organized was used now to go through the top-down process that I mentioned earlier. And top-down costing is nothing but taking your total cost and trying to allocate them down to the different services you have. So in this case, for example, among these three services, testing, support group, and outreach, if you have your total cost, anything that you can trace directly to either testing, support group, or outreach will need to come down to this through some allocation process where you will use predefined criteria. So an example of this would be, anything that they have a lump sum that they spend on transportation for beneficiaries to come to those support group or come to get tested. So that amount, for example, would be allocated down to the different services using the number of beneficiaries that receive these transportation allowances. So throughout the top-down costing, you allocate down, and at the end, you should get a total cost for each of the services, and you can go further and have a unit cost. So what we're going to present first is some total costs for the CSO. You can see that organized in the different categories of costs we had, or organized in terms of the different services that are offered, it's still important in terms of interpretation and how you use this for your CSO budget analysis. The payroll looks to be overwhelmingly the highest level of cost when it comes to the categories, and this can tell you about how much you can be flexible with your cost in the short term, knowing that payroll isn't something you can change in the short term. On the other side, we can see that, for example, MSM services are having a higher percentage of these CSOs compared to FSW, which is female sex workers, and outreach and the other services, which was all legal, housing and stuff like that. There too, it helps you see how your services allocate in your cost, and if you want to change something, what would be the impact. You can go deeper in looking at each of the services, particularly relating to the different cost categories or cost buckets that we defined earlier. And here too, it could really be interesting for interpretation and decision making. In this particular case, what we saw in general was that any activity that was done offsite, for example, support group offsite or testing offsite, and this offsite means you're not in the CSO building, you are doing this at an event outside of your headquarters. Anything like that would have a high fixed portion for service provision and a lower variable portion. So this tells you that you have to be better at targeting those offsite activities, because you already would be putting so much in fixed cost that you can't get back. So you might as well target those activities in a way that would give you the most out of it. And many other things could be also coming from this, but just that's an example. We have also unit cost that we could get from these results, and in this case, testing was important, HIV services. So we looked at testing in particular, and here too, I mean, the fixed part of the cost is important enough that one way of getting more efficient at doing this would be to actually be able to do the number of event that was planned. So in parentheses, you have the planned event, and then the other number, for example, on the second column is what were achieved. So if we look at the two last line, the CSO didn't do as much as planned in terms of event. And again, the fixed part of the cost is such that it's already sunk. So you don't do those events, it means you're missing on some efficiency gain. And then we can see that on the beneficiary side as well, as the beneficiary cost is per event is high for testing on site. So, I mean, what would this be used for? In this particular case, for example, and talking through the scenario estimation, when we looked at the data, there was some thinking around, all right, so FSW, female sex worker, they have another CSO, for example, doing activities for them. We are also doing it. Does it make more sense for us to just shift those activities to those CSO? And if so, what would that mean in terms of change in cost? So this was idea that was floated around decreasing the cost. And we did a scenario for that, and you can see that we had a 20% decrease in cost by just transferring those activities to a more focused group that would just target this type of population. Another key learning was the level of, as I mentioned, fixed in the total cost of running the CSO, which means this is how much you will need to just function. And as you're just thinking through your budget and through the sources of funding, make sure that you at least would have this much. And on another side of this, which is demand generation, it was more clear now how much trying to get to more key population will help achieve this efficiency gain, given the amount of money already spent in making these services available. And in terms of takeaway, I really think the main takeaway here for the CSOs is that this type of costing can help them with their budgeting, with their way of trying to be more efficient at what they're doing, but definitely will help them in preparing any proposals for the social contracting or even negotiating the budget for the subvention that was mentioned before. But also for the government, this could be something that they can support depending on how much budget they have for this type of costing, but they could also make this a good practice and help CSOs arrive to this level of understanding their costs before entering in the contractual obligation that they will have with the government. So in conclusion, this is a study that we looked at helping the CSOs with their contracting process. I should note that a key limitation is the data availability on the CSO side, and that it has to be taken into account. And because of that, I think decision to add or just change some services should be based on not just the cost, but also some other social benefit to be considered when it comes to key population, given the specificity of this type of population. Thank you so much for your attention. Again, this is on the HFG website. So you see the project website on this slide. And particularly if you just go there and type Barbados, for example, it should definitely come up as the report for this. Thank you, and back to you, Sarah. I'm open to questions and commentaries on this presentation.
Thank you, Sophie, for a very clear description of important work in support of social contracting that took place under the USAID-funded Health Finance and Governance Project, as did the development of the Guyana Sustainability Plan that identifies social contracting as a key strategy. And in Guyana, USAID is continuing its support for implementation of social contracting through the Shops Plus project. So let's go ahead and open the discussion now to participant comments and questions. And before I go to the posted questions, I'm just going to give the mic to Ms. Candace Livermore, the Executive Director of Jamaica AIDS Support for Life, to share her response based on her experience leading JASL's collaboration with the Jamaica Ministry of Health. Candace?
Thank you so much, Sarah. Good afternoon, everyone. I felt so proud listening to the two presenters because I am so happy with what is happening in Guyana and again Barbados, and that I think will help the other countries in the region and governments in the region to look seriously at the role of CSOs in the HIV response and how it is that we can contribute. And they support it in a tangible way. As I listened to both presenters, I wondered a couple of things. One was, the role that the NASA played in the costing of the initiatives, if it is that CSOs were already completing their national aid spending assessments and submitting those to that process in the ministries of health as one implication. And then the bit around what portion of what I didn't get clearly from Guyana was whether or not these costs through the social contracting that they have taken on, whether it would be monies that are now being provided through the grants still in the initial stages, or is it that the government of Guyana has actually earmarked its set of funds to support social contracting? Those are just two questions. But on what is happening in Jamaica, I think the big difference between what Jamaica AIDS Support for Life and the Ministry of Health Jamaica has in relation to what I heard a while ago, the big difference is that the contracts in Jamaica are not with Government of Jamaica funds. So whilst the methodology in terms of the competitive bidding, ensuring that the contracts are tied to deliverables and delivering in a particular time frame, usually those contracts are through whether it is PEPFAR or the Global Fund grants that the Government of Jamaica manages. And that is the next step that we have to take it here in country as we are faced with the similar issues as Guyana, where we know the Global Fund is talking transitioning and we are also seeing reduction in PEPFAR funds. And as such, the big question for us, and where I think we would be happy for some support from our neighbors, is for governments there to share with the government here how it is that they now are going to support CSOs through government mechanisms and through government funds. We also do have organizations here that receive government subventions, JASL being one such organization. But the subvention is really, whilst we are grateful, it is not even a drop in the bucket. It's like $200 a month subvention to an organization like a Jamaica AIDS Support for Life that has a national network and facilities across. And other entities do get, but it's a similar sentiment. So whilst we're looking at social contracting though as one element that we really want to learn from, what civil society here in Jamaica has said is basically we also have to look at other funding mechanisms. So we are looking to develop a civil society resource mobilization plan, of which advocacy for social contracting will be one element. But as the ED of JAS, I tell you, I cannot see the government of Jamaica assuming what Global Fund and PEPFAR has over the years pumped into our organization. It would not be a realistic ask because it's almost, to run an organization like ours, it's almost like running a smaller executive agency at the government if they were to assume some of those costs. So, but I think there is enough learning from Guyana. I'm really looking forward to see how that plays out and what's happening in Barbados. One opportunity though, a major opportunity, and this is my final point, in Jamaica to really move our level of engagement and partnership to the next level is the fact that we're at the end of our current national strategic plan. And so we are now working to develop a new strategic plan for the national HIV response. And so the quicker we are able to define what the asks are and what the realities are in terms of like the costing exercise that has been done, and looking at how the benefits of the partnership over the years, then we want to be able to make a strong case for this strat plan to focus on social contracting as one of the areas to continue the government of Jamaica and CSO collaboration. So we're looking at it as an opportunity, and the Global Fund is supporting us to develop our costing estimates for CSOs that are a part of the response and to develop this broad resource mobilization plan. So those are things that are happening within this year, and we're very optimistic about it.
Great, thank you so much, Candace. So I'm going to go ahead and read the first question for Dr. Edwards. And Dr. Edwards, as you respond to this question, please also feel free to react to Candace's comments if you would like to. So the first question for Dr. Edwards is there a specific model for NGOs to qualify for the process or criteria that should be met by the applying NGO? And as a follow-on, is there technical support available for successful applicant NGOs? So over to you, Morris.
Thank you very much, Sarah, and thanks to all who submitted questions. So let me answer the questions, and then I have to make some comments on the excellent input from Candace. So in the context of Guyana, there is no specific model where basically any entity that feels that it can contribute can submit a proposal, and that proposal will be in the pool and will be evaluated. In terms of technical support, our understanding is that some of the NGOs that were supported by PEPFAR previously, they would have gotten technical support in terms of preparing their proposals. Now remember, we from the Ministry of Public Health, we could not be involved in providing technical support to agencies that will be submitting, and then we are evaluating, okay? But as far as I'm aware, through support from USAID, the NGOs that they were supporting through, I forgot the organization in Guyana. Sarah will probably remember what's the name of the organization, headed by Lisa Thompson. That's APC, Advancing Partners and Communities, that they would have received technical support in preparing their proposals. Now, going specifically to Candace's input, she asked about the role of the NASA. That played no part in this, because my understanding is that NASA basically helps the national program, the country and partners to know how the spending actually occurs in different areas. So that had no role in the social contracting. Now, for Guyana, the funds that were made available, those were specifically Government of Guyana funds. So the CSOs were competing for monies allocated by the Government of Guyana. And this was a pilot with the intention that the pilot would have been evaluated, because, as I mentioned early on, our budgetary process, the preparation starts since around June. So there were targets that, or they are targets, a percentage of the targets, the CSOs have to demonstrate ability to reach that. And if I remember correctly, it was 20% of the overall targets by the end of June. And that would be the criteria that would be used to negotiate with the Director of Budget, that demonstrating that this pilot is successful, and therefore the National AIDS Program Secretariat can continue to put social contracting in its budget and increase the allocation that will be made available from 2020. However, I must mention that in the current grant that Guyana has with the Global Fund made resources available to support the process for social contracting, because this is something which is new for Guyana. But in terms of allocations for service delivery, those were specifically from the Government of Guyana budget. And then finally, I must also mention that in this whole pilot, that there's also support through USAID, where the SHOPS project will, if you recall, the limitations, amongst the limitations I had mentioned, was the ability of the National AIDS Program Secretariat to actually monitor the contractual arrangement, the services that will be delivered. And maybe if you've been following or been checking the SHOPS website or USAID website, may have seen an advertisement for a consultant to actually help the National AIDS Program Secretariat in Guyana to monitor this process. So yes, there's additional resources from USAID as well as from Global Fund to support the process, but not in terms of the resources made available for the service delivery.
Great, Morris. Thank you so much for that very comprehensive response. I'm going to give you a little bit of a break and direct the next question to Sophie. So Sophie, the question is, were the CSOs in Barbados getting some support from government in any form, for example, for office accommodation? If so, how was this catered for in the costing? Over to you, Sophie.
All right. Thank you, Sarah. So that's a very important question, and I think in Barbados it depended on the CSOs. Not all of them were getting something from the government, but some of them were. For example, SEED were getting, I believe, subvention. That would be more of the second type, like subvention, or if we want to call it subsidies. So the same way that Candace has mentioned that sometimes this level this money is not very much in terms of the total cost it takes to run these CSOs. They were getting some subsidies in that way, but for the cost part, as long as we're talking costs, actually it doesn't really matter where the money comes from. What's matter is that it's used as a resource to achieve a service. Now, when it comes now to the budget analysis with those cost results, this is where you're mapping up your cost to wherever the money is coming from. And I think that exercise was done with the CSOs, and it helped them understand actually their level of dependence to one source of funding compared to another. So you could see how much you totally spending to get your services offered, and what is coming from who, and if that source of funding disappear overnight, what does it mean for your operation? So for costs, you have to just take into account all costs, but then after you're done with the costing, you want to map those costs to the source of revenue to better understand the impact that losing some of this revenue would have on you.
Okay, thank you, Sophie. I think I'm going to try to squeeze in one more question. So it's for Dr. Edwards, and it says, thanks, Dr. Edwards. Please describe the planned arrangements for monitoring the implementation by the CSOs.
Okay, Sarah, thank you for that question. Yes, so the planned arrangement for monitoring the contractual arrangement between the government of Guyana, well, the Ministry of Public Health, and the entities that been recommended to implement those services. So because one, this is a pilot, you need a dedicated, or we need a dedicated officer to specifically monitor all of the management processes. So, and that's where the advertisement, or the, sorry, not the advertisement, the support from USAID through shops will be directed. So someone that will be monitoring the entire management process of this pilot. Then secondly, we'll need somebody to monitor the quality of services that will be delivered by the contracted parties. So at the minimum, those will be 2 persons. Now, the tools that will be used, because we already been working with delivering services to key population, the National AIDS program has its specific monitoring tools. So we don't have to develop any tools to monitor the services that are being delivered. The person or persons that will be contracted to assist with that process will actually be using those tools, and the specific monitoring schedules will be worked out with the National AIDS program. So for example, will they be going out on a weekly basis to observe in an unobtrusive manner what is actually happening in terms of the populations that are actually being reached, and this package of services that the National AIDS program has, that those services are being delivered as they should. Because it's a pilot, the person that will be contracted through shops will actually, one, be documenting the entire process in collaboration with the Health Sector Development Unit and the National AIDS Program Secretariat, where there will be fortnightly reports, there, of course, there are going to be frequent meetings between the entities to monitor the actual progress, and then there will be an end of support report. We expect the support from shops to be at a minimum up to October. So we will get a status report up to then, and then we'll have some recommendations going forward for the new year. So I hope that I've done justice to put in a nutshell some of the arrangements for the monitoring of this pilot.
Great, thank you, Dr. Edwards, and you answered that so succinctly. We will go to another question, and this one is for Sophie. Sophie, and the question is, what should be prioritized for CSOs who are new to such a costing or who have limited capacity to conduct one?
So thank you for that question. I think the the main thing here would for any CSO is to have a good idea of their cost and how it relates to the structure they're running, and also how much we're talking when we go down to unit costs. Now, the way we did it in Barbados is by no means the way to do it necessarily. It's just one of the way to do it. We know that for this one, it meant a lot of working together with the CSOs, sitting with them, understanding the structure of their cost, and we used maybe tools that they might not be aware of, just being working on those CSOs and just providing the services. So it was technical assistance provided by a USAID-based a project. If you don't have such assistance, doesn't mean you can't do some very maybe high level costing. But what's important is definitely to account for everything that is shared costs. And this might be the problem for most of the CSOs. They would just provide testing services and just think of how much it costs for just the testing part, those kits and whatever consumable, and forget that behind all of that, there's a whole structure that they already have in place, but without that structure, there won't be any testing. So if you're budgeting, if your costs are just based on that, and then you go with that cost to negotiation, you're missing a big part. And if that part now don't have any funding down the road, you're now stuck with some targets that you already contracted to do, and you can't do that. So that's really what the message is here. Try to account for everything that comes into providing these services. Not necessarily the way we did it, but just the idea is to be thorough in what you take into account.
Okay, you are doing such a great job. Let's go to another question. I'm not going to say this is the last one, but this is for Morris. What is your best advice for government colleagues seeking to increase contracting or to initiate social contracting? What is the advice that you would give to government colleagues?
Okay, the best advice would be, one, your policymakers like to have figures, and so if one take home you can get from this webinar, you should try as much as possible to get some idea of what the cost of delivering the services that you're going to contract any civil society organization, what realistically what those costs will actually be, so that one, you don't under budget, and therefore, and especially if your government is going to be like my director of budget, who's saying, listen, this is a pilot, and if it is successful, we'll support. If it's not successful, we wouldn't support. So if you're under budgeting and the NGOs don't really have the true resources, then you're setting them up to fail, and therefore not likely to have social contract, or have the policymakers see social contracting as a viable entity. So as much as possible, if you can get the cost of the services that you want to deliver, and two, try not to have the entities at the beginning deliver too many services, because again, you're setting yourself up to fail. Three, ensure that you have the capacity to monitor what is being delivered, and you can try to ensure that your partners are there to support you in that, because again, you want to demonstrate success, and not only to demonstrate success, but also you want your services to be delivered to the quality that your country definitely deserves to have those services delivered.
Thank you, Dr. Edwards. That's fantastic advice, and I know that it has taken a lot of hard, committed work from you and your colleagues on the ground and the development partners in Guyana So we've finally come to the end of our time. We've covered a lot of ground and we've learned a lot. Thanks to you all for joining and participating. I hope that you found it as interesting and informative as I did. And thanks again to our presenters, Dr. Morris Edwards and Dr. Sophie Fay, and to Ms. Candace Levermore for her reaction. Thank you to Dr. Shanti Singh and PANCAP for collaborating with Shops Plus on this webinar. And finally, thank you to USAID for supporting this webinar and for supporting this important work in Guyana and Barbados. Thanks again for joining. I'm going to hand it over to Shanti for her final closing words.
Thank you very much, Sarah. And this really does bring us to the end of our webinar. I want to join you, Sarah, in saying big thanks to USAID for really supporting this important work in the region, social contracting. On behalf of PANCAP and the USAID Shops Plus project, I wish to say a big thank you as well to all of our presenters, very insightful presentations and much food for thought. Thanks to all of the participants for being here. Just as a gentle reminder, the webinar was recorded and we'll post the webinar recording on PANCAP's website. Please do remember to complete the post-webinar evaluation. We really will appreciate your feedback. And finally, before we close, I encourage you to stay engaged with the regional response. Follow us on our social media platforms, Facebook, Twitter. And please stay tuned for the announcement of the upcoming webinars. Thanks again, everyone, and have a good afternoon.